Hello, class, and welcome to your podcast on liver disease. This is just going to be a general overview. That's all you need at this N150 level. We're going to discuss what the liver does and what would someone with some liver disease look like, and how would we handle that as a nurse? What manifestations would this have? Keep in mind, this does not take the place of your reading or coming to class. So let's first think back and just go over quickly, what are the functions of our liver? Is our body's largest glandular organ. No one can live long without a liver, and if you have a diseased liver, it's not like if you had kidney disease and kidney failure where you can just get renal dialysis. We have no way of replicating what the liver does. So let's talk about some of the jobs of the liver. First of all, it metabolizes. It breaks down our carbohydrates, our proteins, fats, steroid hormones, and most drugs and alcohol that we ingest. So it's basically a filter. If you take a look at this picture real quickly, see our liver is located right here, and it receives oxygenated blood from our heart, so from our hepatic artery, but then it also receives a lot of blood flow from the hepatic portal vein. So our portal vein, these veins here, coming from the small intestines and the large intestines. We actually, when we ingest food, our food goes into our stomach, goes into our intestines, and to keep our body safe, our liver is a filter. You know, it prevents us from being poisoned. So this blood goes into the liver to then be cleansed, you know, to take out any things that would be harmful to us. So that is one huge job of the liver. The food that we ingest comes in and gets broken down so we can use it. Another big thing that the liver does, when we break down proteins to fuel our body, the immediate byproduct of the breakdown of protein is ammonia. Now, ammonia is toxic if left in our body, so the liver quickly converts that ammonia to urea, and then urea gets excreted, because urea is not toxic to us, then it gets excreted by the kidneys. So if our liver isn't there to do that job, that is a huge problem, because our body's constantly breaking down proteins to keep us alive, and if it cannot convert that ammonia, we have a big problem. Something else that the liver does is it's got some specific immunity. Kupffer cells are only found in the liver. So they're produced and manufactured in the bone marrow, but then they travel to the liver to mature, and then they're there. So they destroy foreign cells and also break down damaged blood cells. Our liver also secretes heparin, and then it also stores and synthesizes essential blood plasma proteins, including albumin and our clotting factors. So this is a huge, huge job. Also produces bile. So, you know, it gets produced by the liver and then stored in the gallbladder. And bile breaks down fat and helps us absorb fat. Liver also eliminates bilirubin from the body. So, and the bilirubin is a byproduct of the breakdown of our red blood cells. So let's recap quickly all the jobs of the liver. So detoxifying our blood, storing fat-soluble vitamins, and some fat-soluble vitamins are vitamins A, D, E, and K, which we all, hopefully, you guys will learn or know that vitamin K is the antidote to Coumadin or warfarin, so that has an effect on our blood clotting. Also, formation of plasma proteins, which is very important for keeping our fluid status in our vascular system and not third spacing, causing edema. Synthesis of urea, so again, changing that breakdown of protein waste ammonia into urea. Storing glucose, synthesizing clotting factors, helps us break down fat that is needed to run our body. Secretion of heparin plays a role in immunity, breaks down fats, stores carbohydrates, regulation of amino acids, and production of body heat, and stores minerals. So what happens when the liver has problems, and what are going to be the side effects of this? So if the liver is impaired and we have impaired protein metabolism, drop in albumin levels, and drop in clotting factors, this can lead to a patient with edema, patient with ascites, impaired clotting factors. We recently cared for a patient in the hospital. I received her as my patient, and she was here for a GI bleed. She had just received a couple units of blood. She had already come back from her upper endoscopy where she had 3 bleeding esophageal varices. So they had to cauterize and close up her bleeding vessels. This patient has NASH. It is kind of uncommon, but is non-alcohol fatty liver disease. So she had basically cirrhosis. Her liver was failing. She was only 50, very young. And so she had this swollen edematous belly, which was firm. So she had ascites in her abdomen. She was there for her GI bleed. It was her third time being admitted for a GI bleed. So she was having these constant esophageal varices bleed. And she also was kind of tannish looking, yellow, jaundice. She looked very jaundiced. So just to give you a picture of what this patient with liver disease would look like. So when the normal function of the liver is disrupted due to inflammation or other disease, again, this NASH is kind of uncommon. Some of the other causes of liver disease would be alcoholic cirrhosis, hepatitis, and then there's some other ones you can talk about. Sometimes you can have the liver back up due to severe end-stage heart disease, congestive heart failure because of this backup of fluid. We'll go back and show you that photo again when we start to talk about fluid backup and portal vein congestion. So this impaired glucose metabolism and storage, so you could see these patients could have hyper or hypoglycemia due to this difficulty in the liver maintaining our homeostasis, not being able to store those glycogens and not being able to break down the glucose. So if it's a breakdown issue versus a storing issue and letting and releasing. Reduced bile production, which is going to cause our body, if we don't have the bile to break down our fats, that fat can pass through the intestines and not be broken down. You can also have impaired absorption of all of our fat-soluble vitamins because we don't have that bile to help break down and absorb those fat-soluble vitamins. So you could have some vitamin deficiencies in A, D, E, and then vitamin K. That vitamin K I mentioned before increases your risk for bleeding. Vitamin K is the antidote for that PTINR when you're taking warfarin, but also, just to stabilize our clotting. Reduced, impaired metabolism of steroid hormones. So you could see these abnormal sex characteristics with male and female. A female may have a little more male seeming characteristics and a male might have more female characteristics. So these other complications of liver disease. So you have this diseased liver full of fibrotic tissue. It's not functioning. So you have all this blood pouring in to the liver. So you start to have this increased pressure, so portal hypertension. So the portal veins are those veins that are sending blood from the intestines into the liver. So you start to have this backup and accumulation of fluid coming into the liver because the liver is not processing it properly. Everything is slowed down. It's not functioning. It's getting inflamed. It's getting enlarged. So that extra fluid just sitting there, it starts to back up. So then you can have extra pressure. You have some gorging of this blood flow. And let's take a quick look at the anatomy. So if you notice, here's our liver, and this blood that's flowing from our portal, hepatic portal veins from our intestines, if this is trying to get in here, and we have a roadblock here because of a diseased liver, all this is going to start to get engorged. And notice, if we have a blockage here, the fluid's going to take the path of least resistance. So then you start to have engorged veins in your intestines and engorged fluid going back into the spleen because you've got the spleen sending fluid in. So you're going to have, and then you've got your veins here from the stomach going in. So you have a blockage here. You have engorgement in the spleen and engorgement in your veins here in your stomach and esophagus, and then engorgement in your intestines. And it's for that reason that you start to see all these other manifestations. So this portal hypertension, this swelling engorgement of the portal vein, splenomegaly. So your spleen starts to get enlarged. The spleen is responsible, the splenomegaly is what ends up leading to the drop in platelets and the decreased production of white blood cells. The ascites, which you can see here in this photo, this very, very swollen abdominal cavity, because that fluid, the blood flow trying to come in from the portal system, the plasma proteins start to leak out. You have this extra leaking out of the plasma proteins going in, and you start to have this third spacing of fluid. So water starts to get pulled into the abdominal cavity. So you could, this abdominal cavity is full of fluid. It's probably firm. Esophageal varices, that is what our patient with the NASH kept on having recurrent issues with. So in the esophagus now, those veins get backed up and engorged with blood. So you have these huge blood vessels getting all swollen, and they can easily rupture. And when they rupture, they bleed into the intestines and into the GI tract, and you have a GI bleed. And due to these other issues with liver disease, decreased clotting factors, vitamin K is low. So then not only are they having an increased chance of bleeding because of these varices, but then you've got difficulty with clotting and fixing that problem. And then portal systemic encephalopathy. And this encephalopathy, this happens due to cerebral edema, due to the accumulation of neurotoxins in the blood. So again, this ammonia, if your liver's not breaking down and you've got ammonia floating around, this crosses the blood-brain barrier and is a neurotoxin and can cause inflammation and swelling of the brain. The nervous system, other things like depressants and narcotics can also contribute to this issue. So again, just to recap quickly, portal hypertension, increased pressure causing the blood to reroute itself to lower pressure areas, which then causes ascites. The splenomegaly, because of the portal hypertension and the rerouting of blood, will then cause the increased rate of red blood cells, white blood cells, and platelets to be removed from circulation and destroyed. So this leads to anemia, leukopenia, and thrombocytopenia. The anemia, low red blood cells, leukopenia, low white blood cells, and thrombocytopenia, which is low platelets. And then the ascites, which is that swelling in the belly. Huge belly. That is caused by the hypoalbumin. And then this is caused a third shift space. So third space shift of fluid. So it basically takes the fluid out of our vascular system and pushes it into the tissue and to other surrounding areas. And then esophageal varices, you have that enlarged thin wall veins. They form in the esophagus due to that portal hypertension, that extra blood flow and this extra accumulation of fluid that's now going to a different place, like path of least resistance, and they can rupture and cause massive hemorrhaging. And then, of course, not having our clotting factors and our thrombocytopenia contributes to our hemorrhage. So some other things you might see when a patient walks in. Enlarged liver or tenderness in that right upper quadrant. So if you see some swelling, you really shouldn't be able to palpate a liver on assessment. I don't know if you learned in your assessment course, it's more of an advanced practice, but to be able to try to hook your finger around, have them take a deep breath, and if you feel the liver, you really shouldn't be able to feel it, and would it be tender? Any dull aching in that right upper quadrant, possible weight loss, weakness, anorexia, diarrhea, or constipation, ascites, that swollen abdomen, and then bleeding or bruising. If someone's got decreased clotting factors, you might see that they're much more prone to bruising or easily bleeding. And then later signs listed on the right, that low white blood cell count, so anemia, jaundice. There's a great picture there at the bottom with the sclera tends to be one of the first places you will see jaundice, but also in the face. If you ever blanch, you could try to blanch on the forehead, push your finger in, let it go, and sometimes where it would blanch white, it blanches more yellow. Seeing edema in the legs, in extremities, and then also in the abdomen, and then maybe some neurologic changes, so confusion, but this would be more ammonia and other neurotoxins that the liver is not filtering properly. Infertility in women, and then the gynecomastia in men, so that would be like forming female anatomy. So what are some diagnostic tests that we might look at? Or what are some tests that would be abnormal in the presence of liver disease? So one of the first and foremost ones would be liver function tests. We call them LFTs for short. So liver function tests, the main two ones would be AST and ALT. And actually, we might even want to reverse. You would want ALT first and maybe AST second. So the ALT is known as the most specific enzyme for liver damage, and it's usually released with the death of liver cells. So if you see an ALT elevated, it's going to be indicative of some liver cell damage or death. The AST, it's an enzyme found in the liver and heart, and it gets released and elevated 10 times greater than normal with the death of liver cells. And then the GGT and the ALP, they're more specific though. Their enzymes more related to the bile ducts and often increase when the bile ducts are blocked. So the ALP gets increased with bile duct blockage, and the GGT is an enzyme found mainly in the liver and is a useful marker as well in detecting bile duct problems. So specific to liver would be the ALT first and then the AST. And then the CBC, all the things that we talked about before. So what might you see? You would probably see that low platelet count in your CBC. You might see a low H&H if they have been bleeding, and maybe a low white blood cell count because of the anemia, leukopenia, and thrombocytopenia that we talked about. Coagulation studies, you might want to check a PTINR to see if the patient is within normal range, or is that lack of vitamin K absorption causing them to be a little overcoagulated. Serum electrolytes could be off because of the plasma proteins that are now causing these fluid shifts. Bilirubin would probably be elevated due to the liver's inability to be able to break it down and excrete it, and instead then that bilirubin is sent into the tissues and then absorbed in the blood flow system, like in our vascular system instead. So then our serum bilirubin is high, and then it's forcing our kidneys to have to excrete that bilirubin instead of our intestines, where it should be getting let go of and broken down by the liver and then excreted in our intestines. So albumin. So our albumin will be low, main protein made by the liver, and can usually tell if it's making adequate amount of protein. So the albumin is going to be low. And then glucose could be elevated or decreased, our cholesterol. So all of these things could be abnormal. Our abdominal ultrasound would show swelling of the liver. And then the going down the esophagus would show the esophageal varices, or the enlargement and engorgement of the veins in the esophagus. And then also watching for any sort of bleeding. And then a liver biopsy could maybe help to determine what's happening with the liver, what type of disease is going on, and how severe, the renal failure is, what stage it is in. So depending on what sort of liver disease we have, if we're having some liver issues, one of the first things we're going to do is try to treat the problem that's causing the liver disease. So if it's something like NASH, where that's nothing that we can treat, we're going to our focus is going to be aimed at treating the problems that the liver disease causes, which is kind of what these medications are going to discuss. But keep in mind, if someone has hepatitis, then we're going to try to treat the hepatitis. If someone has alcoholic cirrhosis, then we're going to try to get them to stop drinking, so things like that. So think about, we want to treat the problem causing the disease, but in addition to that, we'll talk about some of these other medications. So medications are used to treat complications and reduce further damage. They do not reverse or slow the process of cirrhosis, unfortunately. So diuretics, that's going to decrease our fluid retention, so hopefully decrease that ascites. Remember, when that belly was all full and swollen of fluid, that can make it hard to breathe. It can make that person short of breath. When they start to get up and move, the diaphragm can't go down. So trying to get that extra fluid off and getting the edema off. So spirolactone would be the first choice, and then maybe Lasix or furosemide. Lactulose and neomycin. This decreases ammonia levels and it helps reduce encephalopathy. So if someone has high ammonia levels, I remember caring for a patient when I worked in a prison. He was in end-stage liver failure and his belly was huge. He was very jaundiced, and he would need to take his lactulose like 3 times a day. So lactulose, it binds with the ammonia and forces, gets the ammonia out. But it causes severe diarrhea, so it kind of excretes the ammonia via the intestines. Beta blocker, this will decrease the hepatic venous pressure, so it's going to vasodilate. It helps to decrease that pressure. So again, all those issues we talked about with that blood backing up, it would decrease those symptoms. So hopefully decreasing the ascites, hopefully taking some of that pressure off the portal because of the portal hypertension, but taking some of that pressure off those blood vessels, and then should decrease the risk of bleeding in the esophageal varices as well. And then ferrous sulfate or folic acid, this is to help treat the anemia. We might give vitamin K to reduce the risk of bleeding, so we might give that. Packed RBCs or FFP, which is fresh frozen plasma, so we might be giving some blood products. My patient with the GI bleed, she received multiple units of blood to make up for her anemia and her active bleeding. And acids as needed. So sometimes with that esophageal varices, I know my patient specifically had some GERD, some issues with some reflux. And then oxapam, that is a type specifically, it's an anti-anxiety sedative that is not metabolized by the liver. Remember, most of the medications we give patients, they're metabolized and they put work on the liver, and the liver needs to excrete them and get them out of our body. So we really want to try to avoid hepatotoxic drugs or any kind of substances that requires a lot of work from the liver to break down. So some examples of that would be you want to avoid alcohol, barbiturates, sedatives, hypnotics, and especially acetaminophen. Acetaminophen is known to be difficult on our liver. So what type of nutritional therapy would we think about for a patient with hepatic disease? So restricting sodium, because again, sodium fluid follows sodium and then would increase our fluid retention. So less than 2 grams of sodium a day would be recommended, and fluid restriction possibly. So we might need to restrict someone's fluid, a fluid restriction of 1,500 mLs per day if needed, on a severe end-stage case. We might want to encourage plant protein, so 60 to 80 grams of plant protein if ammonia levels are not elevated. Again, protein being broken down increases our ammonia levels, so we want to watch that carefully. But plant-based protein would be preferred to animal-based protein if possible. Definitely vitamin supplements. We might need to give them a little more vitamin B, thiamine, folate, vitamin B12, and the fat-soluble vitamins I mentioned earlier, A, D, and E. To treat liver disease, again, we don't have dialysis for a liver. So this patient that I was talking to, her daughter had called and was very, concerned about her mother being in the hospital, and she was concerned about, what can we do to treat my mom? And when I spoke with the patient, she's like, yeah, I'm debating on getting her on a liver transplant list. And so she had not, went that route yet, but that would be one of the main ways you would treat a failing liver, would be on a liver transplant list. There is something called a live liver donator, where I guess someone can actually take a portion of their liver and surgically put it into a patient, and I believe the partial liver will grow and can function and care for a patient. This patient in particular had mentioned the live liver transplant. The doctor did tell her with NASH, it is a progressive disease that, it might give her another 10 years, but then that new liver would eventually become diseased and fibrotic and probably fail eventually as well. And not to end on a bad note, but that concludes the lecture on liver disease. So just keep in mind what would cause the liver disease, what are some symptoms that you would see. So hopefully you'll get to see some of these patients and get to evaluate some of these signs and symptoms in person.